I've taken the lateral ligament, which I'll openly admit is probably less controversial than the medial. But that's the privilege of seniority, I think. So a few disclosures here is I have a potential conflict with the presentation because I will mention some materials that I have some development and royalty positions in. So lateral ankle sprains, dime a dozen. The thing that I think is understated is how often we have residual problems after an ankle injury. So Ken Hunt looked at a American sports experience, and this is the NCAA Division I program, and this is when he was in Stanford. So they looked at almost 1,100 athletes participating in 37 sports and looked over 2 years. And what they were interested in was the foot and ankle injuries that required medical treatment. What they found was that over a quarter of all injuries were foot and ankle. So we should all consider that job security. And the average loss was 12.3 days from sport. 27% of these were referred for a physician evaluation, and 84% had radiologic investigation. The most frequent foot and ankle injury reported in this cohort was lateral ankle ligaments. So the anterior talofibular ligament is the primary restraint to inversion throughout ankle motion, and it is by far the most commonly injured. This is the one that we are going to be focusing on today. Not to forget, the calcaneal fibular ligament is the primary restraint to inversion of the dorsiflexed ankle. It's unique in that it crosses both the ankle joint and the subtalar joint. So when we're looking at testing, is we've got to sort out this idea of anterior drawer and anterior lateral drawer. So the anterior drawer is a total combined laxity of both the tibiotalar and the subtalar joint. So that's a direct anterior pull. Whereas the anterolateral drawer is a direct palpation of the fibula and talus, and you're trying to appreciate the rotation of the talus. So the anterolateral drawer is more sensitive for ankle instability than the anterior drawer. So here's a typical patient for all of us. This is a 26-year-old male, long history of what he'll call small ankle sprains, which means he really didn't get medical care. He plays with the brace and he thinks he's okay. He's wrestling, twists his ankle, again, much worse this time. And clinically, you call this a grade 2, grade 3 ligament tear. It's quite loose when you're examining him. His x-rays are negative. Well, clinical practice guidelines. When should we be doing an MRI? Well, we should do it if we think that this patient injured his cartilage, if we think he had a peroneal tendon tear, if he's had a ligament injury, but it doesn't respond to brace, PT, or rest, or if he has normal x-rays, but you're concerned for an OCD or occult fracture. Well, it begs the question, can we just skip the physician and go to the imaging? How about using MRI to diagnose instability? So this is Jolman publishing in 2017, 187 patients that were already scheduled for lateral ligament reconstruction. So that means a surgeon has identified them as having chronic instability, a surgeon has talked about risks and benefit, and a surgeon has recommended surgery. Well, they had a control group who had no ankle instability, but also had MRI and stress x-rays. And they gave all these patients to the radiologist to diagnose. What they found was that MRI was sensitive, but not specific. Sensitivity rate of 82%, specificity rate only 53%, positive predictive value 73%, negative predictive value 66%. And these radiologists could not pick out the ankle instability patients from MRI imaging alone. Kind of a fascinating idea. So MRI has value as a screening tool for associated ankle pathology, but it is not diagnostic for lateral ankle instability. Well, what are the predictors of chronic ankle instability? Well, Doherty took 82 patients who had a first-time ankle sprain, and they wanted to know at 2 weeks who are the ones who are going to do well and who are the ones that are ultimately going to end up needing surgery. And they had two things that were predictive. Inability to perform a single leg drop test. That's a little bit of a mean test where you're actually asking somebody to land from a height on their injured ankle. And if they couldn't do it, then that's a bad prognostic sign, or if they couldn't do a drop vertical jump. So those are a little bit impractical, but that's what they came up with. So lateral ligament reconstructions, there's 80 or more described. There's all kinds of different categories. I tend to break them into anatomic, which are the modified Brostrom or augmented Brostrom, or the non-anatomic, which are perhaps the Christmas snow. The principles of ankle ligament reconstruction, you gotta respect the isometry. Cannot over-constrain joints. You have to allow for early mobilization, and I don't think you wanna sacrifice local motors. So this is what my algorithm looks like. My first go-to is an open Brostrom with the Gould. My second go-to would be an open Brostrom with a ligament augment device. And my third go-to is what I'm calling the Atlas. It's an ATFL and CFL ligament reconstruction using either allograft or autograft semitendinosus, or my recent experience has been more with ligament augment devices. So let's dig into these a bit. So Brostrom Gould, I think all of us know it. The beauty of a Brostrom Gould is that it respects the normal isometry of the ankle. And in my opinion, you cannot over-constrain the ankle doing this. The Gould brings in the subtalar component of it. Ken Hunt in 2008 had 10 matched cadaveric limbs, and he did material testing in plantar flexion and internal rotation. He found that when you include the calcaneofibular ligament, so you do the dual ligament reconstruction with Brostrom, you get increased stiffness, reduced medial translation of the subtalar joint, and a higher failure torque. Well, if you're gonna do the Brostrom, where do you do it? I tend to repair the ATF and CFL mid-substance. But if you look at this paper by St. Pierre back in 1983, they found that the injury usually is closer to the talus. So at the fibula, they said none of them were at the fibula. Mid-ligament, 44%, insertion at the talus, 50%. So my mid-substance really might only be picking up 50% of the actual injury site in these patients. So Bell published 2016 on the Brostrom. I like this because these are hardcore Navy Academy recruits. They've got 26-year follow-up, 91% good to excellent. That's about as good as it gets in orthopedic surgery. 91% good to excellent. And why? I think it's because it respects all the principles of reconstruction. Well, what happened to the other 10%? Was it the tissue? Was it the technique? Did the knots fail? Did the anchor pull out? Or can we blame it on our patients? So tissue is the weak link. Brown, publishing in 2014, did matched cadaveric mechanical testing, and he did anchor versus suture only and found no difference in anything. No difference in failure torque, failure angle, or stiffness. Failure level was at the tissue level, meaning the suture pulled out of the tissue. It wasn't the suture, it wasn't the ankle, this was the tissue level. So it brings us down to the question about the compromised host. What are you gonna do? Well, I think we'll all argue in those cases, you need to augment the tissue. Lots of options. You can use autogenous sources, you can use allograft sources, depending on your local ability to source that, xenograft options, or prosthetic options. And I'm gonna talk more about the prosthetic options today. So Porter, publishing in 2019. Porter's out of Australia. He had 50 chronic ankle instability patients, and he randomized them. So this is level 1 data. The first group was randomized to a modified Brostrom, done the way that I just described. The second group was a primary repair with a ligament augment device. At 5-year follow-up in 42 patients, there were 2 failures in the modified Brostrom, none in the ligament augment group. Ligament augment group had significantly better scores at 1, 2, and 5 years, and the 5-year Tegner scores were higher in the ligament augment group. His material was a 3rd-generation polyethylene synthetic ligament. It's not on the market here in the United States. There are other material options. You can use auto or allograft to augment it. You can use polyester, which is a strong but non-resorbable material. This is what Dr. Preisel would refer to the non-stretch. Or you could use a knitted polyurethane, a strong dynamic resorbable, which has a little bit more stretch capability. And what do we know and how can we pick between these options? Well, the non-degradable options, these polyester implants, and the prototype for that is the internal brace, they provide immediate mechanical augmentation of the surgical repair. There's no doubt they make it stronger at time zero. They do lose some integrity over time at the junction to the host. And the biggest worry is twofold. One is stress unloading of the repair by the implant is associated with failure. So it's not physiologic. It's not sharing the load with the host tissue. And that's probably my biggest beef with it. The synthetic and degradable, the prototype here is a knitted polyurethane urea copolymer that goes by the trade name of Artelon. It's non-permanent support with matrix dissolving over 5 to 6 years. This is a load-sharing dynamic textile. It stretches, and it has fabricated patterns to encourage cell infiltration with maintaining structural integrity for repair. So no matter what you're doing, we have to think about what are we trying to achieve. And I'm going to argue that what we're trying to achieve is a check rein prosthetic concept. And the idea is we're using it as a protection for the brostrum. We want the brostrum to take the load. We want the brostrum to be your day-to-day function. We don't want this ligament to take the load. We want it to add more as a check rein. So what follows, the risk profile is you over-constrain it, and you all of a sudden create non-isometry in the joint, and that's going to create problems. And the stiffer the material you are, the higher the risk you're going to have to provide this over-constraint. So let's look at a little bit of data here. So this is Rich Diasa when he was still at Harvard. And what he's looking at is anterior talofibular ligament mechanical behavior during pronation, dorsiflexion, as well as supination and pronation. And this ligament elongates and shortens up to 30% during normal range of motion. So I think we'll all argue if we're trying to somewhat replicate that, we need a material that perhaps can do the same thing. Let's take a look at this. So on the right is looking at intact cadaver anterior talofibular ligament behavior during tensile loading. And on the left is what we'll call a stretchable ligament augment device. It matches up reasonably close to the native behavior of the anterior talofibular ligament. Now let's put these side by side. Stretchy on the left and not stretchy on the right. So a very rigid device on the right and a very flexible one on the left. And you can see that that check rein that doesn't have the ability to stretch drops off a cliff. It loads and then it drops off the cliff. And it just does not resemble normal ligament behavior. So where do things fit in my practice? So native ligament repair versus anatomic reconstructions. So my indications where I do something besides or on top of a brostrum is generalized ligament laxity, high BMI, varus hindfoot, or if this is revision surgery. The Priss publishing in 2010 was using peroneus brevis grafts with an anatomic reconstruction. And he was saying that at 20 degrees, it was superior to brostrum, but be careful, even using this peroneus brevis graft, is he was interfering with coupled axial rotation. Miller trying to do this with a little different technique. This is an allograft hamstring, but these are clinical outcomes, and the patients did well. So maybe there's a little bit of decoupling going on, but at 32 months, patients were doing well with no recurrence. This is where I am in 2021. So I'm using an anatomic weave pattern that we're calling the Atlas technique, and that stands for Artelon lateral ankle stabilization. And we're going to use it in this type of a technique. So we have tunnels in our fibula, we have one in our talus, we have one in our calcaneus. And my technique is I pass it into the fibula first, secure it, I pass it into the talus and fix it. I then pass it into calcaneus and fix it. I fix the calcaneal tunnel, allowing the foot to come to 20% inversion before it tensions. And each one of these tunnels, my graft is fixed with an interference screw. These are, I use peak interference screws. I'm not sure it really matters which interference screw that you use. Our experience is over 200 clinical cases. We've got several papers in development, and this has been an overwhelmingly positive experience for me. And it's simplified my approach to lateral instability because I don't have to rely on the allograft anymore. So I've got my standard brostrum. If my tissue's not quite good enough, I'll do a brochure and I'll augment the anterior talofibular ligament. If it's really just not good tissue, then I'll do the Atlas technique. And I've got this material on the shelf, and it allows me to really play it out at the day of surgery. So a couple cases just to walk through this. This on the left is a typical varus ankle arthritis patient. We did a in-bone total ankle replacement with ligament reconstruction on that. We are looking at our isolated series of in-bone 2 with Artelan, and we're looking at coronal and sagittal x-rays. What we're seeing is very good stability with this. Ones that were translated preoperatively, we are able to reduce them back into their joint and hold them. So the question I'd expect you to ask is, can I do the same thing with the brochure? And that's what we're trying to get to here. So this is a bigger study. We've got 40 total ankles, 21 Infinity, 13 in-bone, 6 Cadence, 25 brochure, 15 Atlas. Primary outcome was recurrent instability with a minimum of 1 year follow-up. Our average follow-up is 20 months. Our preliminary data says they both do well, so we're helping patients, but we are seeing a better and more sustained correction in the Atlas group. What I mean by that is varus reconstruction in total ankles tend to want to settle a little bit back towards varus, and in our Atlas group, we're seeing less of that tendency. So in summary, chronic lateral ankle instability. Remember, the anterior lateral drawer is the most sensitive for ankle instability. The anterior drawer fools you because the subtalar joint comes into play. Imaging cannot guide treatment decisions for chronic lateral ankle instability. The reason to get an MRI is to look for other stuff, not to confirm ligament tear and not to decide if they need surgery or not. Brochure is effective in patients where there's sufficient healthy tissue. It's still my #1 go-to, but ligament augment devices closely approximate native ATF strength, but be careful of overconstraint and pick the augment material carefully. I would argue for something that's got a little bit of stretchiness to it. Thank you.